Let me just introduce myself. I'm Neil Brown, and I'm the Director of the Community Support Program in the Center for Mental Health Services, and also the Director of the Transformation State Incentive Grant Initiative. And this is a webcast, and I'm pleased to welcome everyone to the webcast on Psychiatric Advanced Directives, or PADs for short. The goal of today's session are to review what psychiatric advanced directives are and how they can be used as a tool to empower consumers in directing their care during crises, to promote shared decision-making, and to support recovery and transformation in the treatment setting. Also, information will be shared on the lived experience of using a PAD. This includes a discussion about the personal experience of creating a PAD, the pros and cons of having the PAD, the use of the PAD as a recovery tool, and lessons learned in the process. And after the presentations, you will have an opportunity for questions and answers. It's my pleasure to introduce to you our two presenters today, Dr. Marvin Swartz and Mary Blake. Marvin Swartz is the Director of the National Resource Center on Psychiatric Advanced Directives and Professor of Psychiatry at Duke University Medical Center, and has a long-standing clinical and research interest in PADs. Dr. Swartz, with Duke collaborators Drs. Jeffrey Swanson and Eric Elbogen, has conducted numerous studies on interest in implementation of PADs. The National Resource Center on Psychiatric Advanced Directives is a collaboration between these Duke colleagues and the Bazelon Center for Mental Health Law, including Dr. Robert Bernstein, Chris Koyanagi, Ira Burnham, and Edith Coakley. The NRC-PAD website is a central gathering place for stakeholders to learn about psychiatric advanced directives and how to complete these legal documents. The NRC-PAD aims to assist in implementing laws that support self-determination and high-quality mental health care. In June of this year, we were excited to have Mary Blake join our staff in the Center for Mental Health Services Community Support Programs branch. As a public health advisor in our branch, she provides management and technical assistance for recovery-oriented and mental health support services programs for adult consumers with mental illnesses. Previously, Mary was the co-founder, president, and deputy director of training and development for the Consumer Action Network, or CAN, in Washington, D.C. She has spoken and trained extensively on mental health recovery, stigma, psychiatric advanced directives, among other issues. She also developed, wrote, and published with the University Legal Services in Washington, D.C., an advanced planning for mental health workbook that allows consumers to use the advanced directives development process as a means to plan for success in the workplace. So I'd like to start with Dr. Swartz.
Well, thanks very much, Neil, and we're really excited to have this opportunity to talk to you all about psychiatric advanced directives, and I'm thrilled to be joined by Mary, who has first-hand experience with these legal tools. So what we're going to do here today is I'll be presenting some information as background. Mary will be presenting additional information as background, and we'll have a back and forth between us trying to articulate some of the key concepts and advantages of psychiatric advanced directives. And we will, right now the lines are closed so that you all don't disturb each other, but depending on how many people are participating, we will probably open the lines up at the end for question and answer. In addition, you can send emails by send us questions by hitting the bubble that has a little conversation tool at the top, and send us. You can send me questions that we'll come back to at the end, and I can share those with Mary. So let's get started, and hope you gain a lot from this information. So the goals of advanced directives are an effort to ensure that patients are treated according to their wishes, and also as it's a mechanism, we think, to encourage a more informed and open dialogue between patients and their treatment providers. So that, and I think you'll hear this very clearly from Mary, that one of the opportunities this gives consumers in the process of creating an advanced directive is the opportunity to sit down and talk about the treatment process and to think and have an open dialogue about what's worked, what hasn't worked, and what a consumer might wish for in the future. So what are they? And I hope at the end of this talk you'll go to our National Resource Center, NRC-PAD.org, and read more about your state or other issues that you might be interested in. But let me give you a general legal background, understanding that each state may have slightly different variants of psychiatric advance directives. So PADs, or Psychiatric Advance Directives, are legal documents that allow a competent person to refuse or give consent to future psychiatric treatment. So it's a mechanism by which a person with mental illness who is doing pretty well can, during a period of reflection, think about what kind of treatment they would like in the future and create a legal document either to consent or to refuse future treatment. Another aspect of this, and we'll get into this in a little bit more depth in a minute, is that it's also a mechanism to authorize another person, a so-called healthcare power of attorney, to make future decisions about mental health care on behalf of the mentally ill person if he or she becomes incapacitated in the future. Mary, you want to comment some more on this?
Thanks, Marvin. Really looking at the role of the Psychiatric Advance Directive, it's basically a healthcare directive that allows mental health consumers to state their mental health care wishes in advance for those occasions when they may become unable to communicate their wishes or to make their wishes known. First, I'd just like to say that from the consumer perspective, advance directives can sometimes be hard things to think about because they require us to think about times when we're not able to communicate our wishes, when we've been deemed incapacitated, and Marvin will go through what that means in just a minute. So the fact of the advance directive as the legal document and when it goes into effect is something that creates some concern for some consumers. But the advance directive is a way for consumers to kind of be directors of their health care in those times when they can't communicate their wishes. And in that sense, they're really great tools. And I will talk about my own experience in creating and actually having an advance directive go in force to illustrate how you negotiate the process of deciding to create one and to deal with thinking ahead to those times when you may not be able to make your own wishes known, and so forth. So I'm going to pass it back to Marvin, who's going to talk a little bit about why PADs are important.
Sure. Well, thanks. So one of the particular features of PADs that makes them important is their legal status. And part of the background to their special legal status is that the Patient Self-Determination Act of 1991, or the so-called PSDA, required that hospitals and clinics that participated in Medicare or Medicaid assisted medical patients in completing medical advance directives. And as we'll talk about in the future, you'll see that one can create a psychiatric advance directive under a special statute for psychiatric illness, or occasionally under medical advance directives. You can do it either way, depending on the state you're in. And in states that have these special PAD laws, the PSDA requires that hospitals and clinics comply with that law for the psychiatric advance directive as well, so that in at least 25 states that have specific psychiatric advance directive laws, and that includes the transformation states, the Patient Self-Determination Act requires that hospitals and clinics that accept Medicare and Medicaid comply with the aspects of the PSDA that would apply the Psychiatric Advance Directive. So that means that consumers who are interested in creating a Psychiatric Advance Directive need to be given information about it, that the Advance Directive needs to be put on file, and so on and so forth. So PADs are important, particularly in the 25 states that have specific set-aside laws, but there's also mechanisms to create Psychiatric Advance Directives under General Medical Advance Directives laws. Now, just as an additional point, the recent final rule on seclusion and restraint that was issued by CMS specifically said that one of the conditions of participation for these hospitals and clinics was that people were offered an opportunity to create an advance directive. So we're hoping that even more attention is going to be paid to advance directives in the future. Well, what are some of the benefits of PADs? Well, we think that it's a great way to support patient autonomy and empowerment in mental health care because it's a way for a consumer to think about and to articulate a treatment plan and a care plan that will most help them during times of crises, but also to let people know what kind of care works best for them at other times. It may be a way to reduce involuntary treatment because one aspect of a PAD may be consent to hospitalization during periods of incapacity, which should mean that the consumer could have, under many circumstances, could avoid a involuntary hospitalization under a voluntary consent that was made part of the PAD. It may also help to improve continuity of care because, as we know, many consumers find that they end up in different places in the mental health system, and one of the great benefits of a PAD is that it's sort of a précis or a summary of one's history and treatment preferences, and so it can be a very concise medical record or psychiatric record that can be communicated to people, and as a result, it may improve continuity of care, communication between providers, and it also can assist in the informed consent process. And because most of the statutes that have Psychiatric Advance Directives as an element have a limited waiver of confidentiality, it may also allow, if the consumer chooses, a way for people to share information in a more easy manner than is possible under usual confidentiality laws. So that, for example, the consumer can say, I want my records to be shared with these people during periods of incapacity so that people can communicate better.
The PADs also serve the purpose of, as Marvin had mentioned in the last slide, they really are also helpful outside of their legal status. They're very helpful in serving as recovery tools and treatment planning. And just to kind of illustrate, I actually, in my history, had some long-term institutional care, and then when I was being returned to the community, was cycling in and out of hospitals, and in the late 80s, I had a psychiatrist who proposed the idea of a Psychiatric Advance Directive, which I will talk about throughout the course of this particular presentation. The interesting thing for me about the idea of creating a PAD is, whereas it was very difficult for me to get hospital staff and some of the other providers to buy into my wishes on a treatment plan, as a legal document, I knew that they pretty much had to follow my instructions for the most part, and I had a strong advocate in my psychiatrist to assist in that. But beyond that, going through the process of creating the PAD, I was actually able to start thinking about the fact that I could make my own decisions. That was something foreign to me previous to working on the PAD, and therefore it provided a context for me to to look at what does work and what doesn't work, where my thoughts carried weight, and it allowed me to have frank conversations with my psychiatrist in a very different way. So rather than for me to put back on her, well, this is what you need to do, the very structure of the PAD was, what do you think works? What has your history shown that works, that doesn't work? Let me think in a different way about treatment. And so, therefore, it gave me actually a better partnering relationship with my psychiatrist, which we could then leverage with the other treatment providers involved in my care, and allowed for almost crisis planning and safety planning, which was really transformative for me.
Great. So, and we're going to get into some specific examples of it, but one of the reasons we think about PADs as a recovery tool in treatment planning is that it allows a consumer to make decisions for care in advance, to sit down and talk to whomever they wish. They can talk to their case manager, their psychiatrist, other members of the treatment plan, and then memorialize that in an actual document. And for the folks we've worked with at Duke as part of our research studies, we've seen that for many consumers, this is a very empowering activity, and it provides a context for a consumer-driven treatment plan, even though it's designed only for periods of incapacity. The fact that it covers all kinds of information can be very empowering and can include information about treatment even during periods that aren't part of crises. And so it encourages consumers to plan proactively for their recovery and set the stage for ongoing partnering relationships with all their care providers, and can be consistent and mutually informing with crisis and safety planning. And I think Mary will be able to illustrate how this has worked for her. Did you want to say something here, or should I go on?
No, I think we can go on.
Okay.
Mm-hmm.
So making a PAD in general rules of thumb, and I've been on the one end of it, helping consumers do it, and then Mary also has experience that she'll talk about doing it herself. So just as a general rule of thumb, and a lot of this is taken from North Carolina's specific statute, and it varies a little from statute to statute. Incidentally, on our website, when you go to your state, we have very specific information about each state, and so 10 most frequently asked questions about PADs, and you'll have very specific information you can look up. So in North Carolina, a PAD can be executed by any adult of, quote, of sound mind, and then has to be signed in the presence of 2 witnesses. The witnesses shouldn't be a relative or a person's doctor, or mental health provider, or other staff, so that there's no conflicts of interest, and then is presented to the doctor and other mental health treatment providers. And in many states, that document then needs to be notarized.
Yeah, now, in my particular case, the people that I actually got to witness my PAD actually just happened to be two professors. I was taking occasional classes at university, and they were I didn't have a large network of people that I felt comfortable going to. These were 2 people, and that I had contact with on at least an occasional basis, and so I asked them to be the witness. And fortunately, in the District of Columbia, we weren't required to notarize our documents, and as Marvin said, that varies from state to state. And so one of the things to consider is when I've done work talking with consumers in the District of Columbia about PADs, there are a lot of questions about who can sign as a witness, and so those kinds of things really should be clarified with consumers as they go through the process. And also to make sure that people understand that a RAP crisis plan can really provide a lot of the information that would go into to a psychiatric advance directive. However, because there are certain legal requirements that vary state by state, in order for it to become a legally valid document, those other requirements need to be looked at.
Sure. And we've had consumers who have asked to put their RAP in their advance directive.
Exactly.
And that's, I think, worked out really well for people. Now, as Mary's mentioned, these two issues can be barriers to people. One, many consumers have trouble finding two witnesses, or maybe too shy to approach people, and may not know about the notary process. So in our facilitation process, we train people to help consumers, round up two witnesses and walk through the notary process. But that can be a barrier for folks. So just to be clear, there are often two parts to the PADs, and it can be structured in different ways in different states. But at least conceptually, it's important to realize that there's an instructional directive, which is similar to a living will. So this is a set of instructions which documents wishes, consents, or refusal of future care. And then there's a separate piece, which is called the healthcare power of attorney, which appoints another person to make decisions during crises and may be designated with limited or broad powers. And at least in North Carolina and many states, you're not required to have either. And in sub-states, you can have either or both. So, for example, in North Carolina, you can have a standalone instructional directive, a standalone healthcare power of attorney, or both. We recommend for our folks that they always have a healthcare power of attorney, unless they have strong feelings against it, because we think that during crises, having someone who can speak for you and articulate your wishes beyond the written page is very helpful. But there are two pieces to this in many states. Sometimes they're part of the same statute. Sometimes they're in different parts of statute. But ideally, you would complete both parts.
Yeah, and the other thing to remember is that the terms used for these documents may vary from state to state. In the District of Columbia, an instructional directive is actually called an advanced instruction for mental health, and the healthcare power of attorney is called the durable power of attorney. So just remember that the actual term may vary a little bit, but conceptually they're very similar.
Yeah, thanks for pointing that out. So, in the transformation states, each of the states has some kind of PAD. So of those two elements, all the states allow a healthcare power of attorney with specific instructions related to mental health. All but Missouri allow an advanced instruction for mental health decisions. So in the state of Missouri, one could write a healthcare power of attorney and put mental health instructions in it, but there is no standalone separate instructional directive in Missouri. We don't think that that's a particular barrier at all. We have had consumers who just did the whole thing within the framework of the healthcare power of attorney or durable power of attorney, and it worked out fine for them. So that shouldn't be a barrier. And in addition, and I hope we'll get into this in the Q&A period, you can, in most states, you can also execute the psychiatric advance directive under a medical advance directive. So at least to the states we're talking about today, have enormous opportunity to use PADs.
Yeah.
Now, I think Mary, you're going to talk about this slide.
Yeah, and just to let people know, we're going to go into more detail about each type of directive as we go through this presentation. But I just wanted to talk a little bit about the process that I went through and even thinking about creating a PAD, because as I said, that I had been quite institutionalized, and so even coming together to look at what my wishes were, I was kind of counterintuitive to what I knew, and so there were a lot of things that I needed to do in order to even move forward on creating a PAD. And one of them was to really work with the psychiatrist around kind of troubleshooting. We'd go back and we'd look at the the cycling in and out of the hospital, and what did I think was really, getting in the way of my being able to stabilize in the community, what needs weren't being met, what was happening when I was in the hospital that was helpful or not helpful. And it was not like this very linear conversation. I mean, because I was fragile and often emotionally distressed, it wasn't a nice, easy conversation. It would go back and forth and back and forth. But we started to see that there were a number of things. One is the second I could find myself out of the hospital, I would do it. And unfortunately, I would often go out extremely fragile and not have the tools nor the supports in place to help me deal with being outside the hospital. And the other thing was was looking at what are my various support systems and who are my go-to people. So the first step was really all about collaboration, and in particular it started with this particular psychiatrist. She presented the idea to me, and we looked at different templates. I mean, these things were brand new on the horizon in D.C., and so they were unfamiliar to many places and even the hospitals that I would go in and out of. So it was really kind of looking at how I could put my wishes down in such a way that they would likely be honored. And so we pretty much decided that I needed an advocate, and that advocate was going to be my durable power of attorney. So my first PAD really was a durable power of attorney with some instructions. So a health care power of attorney with some instructions built in. And so then I needed to think about, well, who would I even want to entrust with that kind of responsibility? It was somebody, there were a lot of things that I needed to consider when I was thinking about who those people would be, because I had a very small circle of people in my life that were active in my life, and I certainly didn't want it to be my family at that time, because in my view, my family had been the impetus for involuntary treatment. So there was not a huge amount of trust there that they wouldn't substitute their own best interest thinking and override what I might say that I want in advance. So I was going through a big process of deciding, did I have somebody I felt who could go to bat for me, and who might that be? I was able to touch base with a couple of attorneys, just to ask them, because I was very untrusting and I wasn't sure this was a good idea at all. And so I was able to get some good advice from attorneys. These were attorneys that were working in the public sector, so I didn't have to pay them. And my doctor recommended actually that I consult a medical ethicist, and so she identified some medical ethicists at the various schools in the area of Washington, D.C. And then really the biggest trick is, what do I want my PAD to do for me? What are my immediate goals for my PAD? And we decided really that my immediate goals would be to consent to hospitalization, and to consent to holding me in the hospital, even if I could technically sign myself out, to write an instruction that would give some authority to my doctor and to my power of attorney, my healthcare attorney, to make decisions about holding me in the hospital, and those decisions would be made on some clear instructions from me in my advanced directive. And I listed out a series of observable signs that they would go on, and then they would bring in 2 outside doctors to evaluate me, and then the PAD would go in force. Now, even though that felt to me like I was taking control, it also felt like I was giving up control. So I would create the draft, I would revise, and through that whole process, I mean, that was a little bit over a year of creating this first advanced directive. But what really also happened in the process is I was creating trust relationships with the people that I invited into the process. And so that was really the launching of my initial PAD. And what I would always recommend to people is that process-wise, better to go slow and really use that process to build your relationships and your engagement with the people you've invited into the process, rather than trying to check off a box that I've got this advanced directive and not really put some good thought into it. So now Marvin's going to talk a little bit about, in greater detail, about what an instructional directive is.
Okay, great, thanks. So the instructional directive, and if you go to the website and look at various state forms, which we've posted there, you'll see that it's pretty straightforward. It usually cues the person to think about particular types of decisions they'd like to make. So they can use it to document just about anything. So the North Carolina form, in fact, says things like, do you know what sorts of things will lead to crises? Are there things that help during crises? Are there things that you would like mental health providers to do? But then it also walks you through specific decisions that are most salient during crisis care. So it asks you to make decisions about which hospital, do you consent or refuse hospital admission? If you consent to hospital admission, are there hospitals you would like to go to? Are there hospitals that you would prefer not to go to? Are there medications that you would like to take? Are there medications you don't want to take? It allows you also to give reasons for each so that people will understand the reasoning behind them. All of these are written in a document. Now, some people just write them out or type them freehand and append them to the forms. So it can be in different formats. But the basic idea is this is not very complex. I mean, it sounds complicated, but it's just really a person writing a care plan, a structured or formatted care plan for times of crisis. And the other thing that is very important for everybody to understand is that the instructional directive, although it gives advice and can be very helpful information for all providers, it only legally takes effect in the event the consumer loses the ability to make or communicate decisions. So only during periods of incapacity. So the clock starts on the instructional directive in terms of its legal effect when a person is declared incapable, and it lasts as long as the person's considered incapable. Now, in North Carolina, that means that a physician or a psychologist writes in the record this person is incapacitated, and that's when the clock starts on both the instructional and the healthcare power of attorney. So that's the way it works.
Yeah, and if you look at the Bazelon Center template, what you would see there is some great ways to facilitate conversation about what things work and what things don't work. Because I can't remember verbatim some of the items, but it's when I'm feeling agitated, it helps me when, or it helps me too, and then it gives a series of options that the person can check off, or that the person can kind of look at to see which ones fit for them. So, for instance, for me, I had a lot of history going into seclusion and restraints, and so I was a person with a history and known to the hospital. So when they would see certain signs, they would automatically say, okay, time for seclusion and restraints. So what I was able to do over time with my PAD was I was able to say things like, when I start talking to myself and getting agitated, it is helpful for me to pace or take a time out in a quiet space by myself. And then over time, I learned that if I gave a reason, it would help people understand that this wasn't just Mary trying to get over, but there were reasons why it was helpful. And I would say pacing is a key way. I call myself when I hear voices or I'm distressed and I'm in a confined space. being in a quiet place helps reduce all the distraction and sensory stimulation so I can focus and relax. And, it's not, people shouldn't have to give a reason, but sometimes giving reasons as to why certain things help is helpful to the facility that's providing the care or the hospital, because it gives them a context to understand why this request or this preference is being stated.
Great. So I think I'm glad you brought up the issue of the Bazelon templates, because if you go to the Bazelon website, you just Google Bazelon Center, you'll see those templates, and that's a great way to have a conversation with someone, because sometimes consumers have very specific things that they're worried about during periods of incapacity that they may not feel think about. For example, we had one consumer that was very worried about who would take care of her children if she got sick. And, what looking at the Bazelon template helped her think about was, okay, that's an issue. That is something I'm concerned about, and I want to make sure I put this in my instructional directive. So it's a very good way to inventory people's concerns. As we've said, the instructional directive can have just about any kind of information: who to contact in the case of a crisis, what can cause a mental health crisis, what might help to avoid hospitalization, how the person generally reacts, anything that the consumer wants to convey, that the consumer feels is important information, can be put in the instructional directive.
So, for instance, also the fact that I spent a lot of time in seclusion restraints. One of the things that I was able to do was to give an order of preference of the kind of invasive interventions that might be used. And I put the restraints at the bottom, and I was able to say that I had traumatic events in my past and that the restraints were particularly triggering. So in the event that you had to do some kind of involuntary procedure, I would prefer that you put me in the seclusion room first, and then if you felt, if there was no way around it, you had to give me involuntary medications, that would be second, and the restraints were really the last resort. The fact of the matter is my ability to articulate an order of preference and the reasons why, we started to see a sharp decline in any of those procedures because people were starting to understand that there were other things going on for me, so that when people came at me, it was actually heightening the crisis rather than really being helpful at all. And then the other thing is that over time in my instructional directive, I was able to start to articulate how hospitals themselves could be triggering and not all that helpful to my recovery, and so we started to build in the use of crisis beds, and we had that option in the District of Columbia. So it was kind of an alternative to hospitalization that was more of a natural-like setting that had a pretty good staff to client ratio, but these were people who were really trained in using different methods and helping us learn self-management techniques and self-soothing techniques. And so that was, over the course of time, the advanced directives would change as my knowledge about what works for me and what doesn't work for me changes, as well as my health status changes, and so my needs change. So that was very helpful.
Okay. So one of the questions that inevitably comes up is, well, what is this? What does incapable mean, and what does it have to do with? What I said a moment ago is that. I skipped. I'm sorry. Let me do this slide first. So, what is a doctor and staff to do with an instructional directive? And actually, this is the same as what they should do with a healthcare power of attorney, is that they, one presented with it by a consumer, they have to make it part of the medical record. They act in accordance with the instructional directive when the patient's determined to be incapable, and notify all other providers to follow the instructional directive or the healthcare power of attorney. So what happens when the person gives it to the doctor or the staff is it becomes a part of the medical record and goes on the record wherever the person chooses. Now, in addition, in North Carolina, our Secretary of State has a website that allows people to store advanced directives, both medical and psychiatric. And so when consumers wish, we also put their instructional directive up on this website, and they then give the passcode to access it to people during periods of crisis. But doctors and staff have to make it part of the medical record, and then they have to act in accordance with it to the best they can. And we'll talk a little bit about exceptions to that during periods of incapacity, and also notify other people of its existence. So what is this incapacity idea? I'll give you the terms in the way it's defined in North Carolina, which may seem a little circular to people, but it's, in the opinion of a physician or eligible psychologist, the person currently lacks sufficient understanding or capacity to make and communicate mental health treatment decisions. So, in other words, the person is not incompetent, so this isn't a legally determined, legally adjudicated state. It's a clinical determination that a physician, or this is in North Carolina, a physician or eligible psychologist feels that the person is, during a period of crisis, is not able to communicate decisions or unable to understand the decisions in front of them. So it's a bedside clinical determination that gets written in the record, and at the moment that the physician or psychologist writes in the record, I think this person is incapacitated, that's when all these mechanisms take place. That's when the instructional directive and or the healthcare power of attorney takes effect. So it's sort of a pivotal issue what incapacity makes, and also physicians and psychologists, at least in North Carolina, need to know that that's, if they want to assist the consumer in using their advanced directive, they have to declare the person incapable for a temporary period of time. One of the great areas of conflict or of controversy about advanced directives, and I'm sure Mary will have some comments about this, and consumers have great concerns about this, is do clinicians always have to honor the instructions? And if you go to the website and look at your particular state, you will see that there's various types of exceptions. And if you think about it, there have to be some exceptions to following the advanced instructions that just follow logically. For example, if a consumer asks for something that's not feasible in North Carolina, then the clinician doesn't have to follow it. So, for example, say a consumer asks to be flown to the Betty Ford Clinic from North Carolina. That's not feasible. And so the clinician isn't bound to try to do that. The clinician just has to write in the chart, this is why I couldn't do this, or if the person doesn't have the kind of insurance that would help them get into that hospital and isn't able to bear the cost, or, can't make those kinds of arrangements, they can document that. So feasibility is one reason a clinician may not need to honor the instruction. In North Carolina, if the instructions aren't consistent with generally accepted community practice standards, it can be, quote, overridden. Or if the treatment requests interfere with treatment of an emergency or can be overridden by involuntary inpatient commitment. Those are all types, or conflict in general with other laws. Those are all reasons why an advanced instruction can be overridden in North Carolina. And this does give concern to consumers, but, in passing these laws, one way the medical community, the psychiatric community was, sort of made more comfortable with the laws is to put into them ways in which exceptions would be accepted. Now, a very important aspect of this to realize is that even though one aspect of an advanced instruction may be overridden, the rest of the document still takes effect. So even though I might not be able to send send my patient to the Betty Ford Clinic, I still have to follow all the other instructions that are feasible and aren't, part of the exception.
Yeah, I mean, it's absolutely true that that the issue of whether or not clinicians will honor the instructions is a big reason why many consumers are not on board with the idea of psychiatric advance directives or have concerns about them. There are a couple of things that people can do to kind of deal with those concerns. One is when you're in the process of creating your instructions is to find your champion on your treatment team who's working with you and really can be your advocate, your healthcare advocate around the issues that you're putting in. Two is to it helps to give the reasons, especially if you're making decisions about medications and you're saying, this particular medication I do not want. So then if the consumer can start to give the reasons for it, it helps to get some understanding by the healthcare professionals. And then I think that the last thing is really to get information out to practitioners and the medical community that, early data is showing that consumers don't typically create treatment preferences or advanced instructions that would be contrary to their health. And I don't know, Marvin, if you wanted to talk a little bit to the study that you were doing in North Carolina on this very issue, because, I was working with the District of Columbia in creating advanced directives policy for the Department of Mental Health, and that was the big bugaboo from the medical director was really concerns about, well, what if consumers say they absolutely want a medication that's going to kill them because they're allergic? And I think one of the tricks is to educate the medical community that, generally speaking, that doesn't actually come up as an issue.
Right. In our process, and I'm glad you brought this up, Mary, when we have facilitated PADs for consumers, and so now we've completed hundreds of PADs now with consumers, we have not had any consumers who refused all treatment. Mm-hmm. We've had no consumers who refused all hospitalization or all psychopharm treatment, and when we rated independently, so when a psychiatrist blind to who did the advanced directive or how it was done rated them, we found that a very high percentage were consistent with what a physician would regard as good medical care. So this fear that consumers are going to write these manifestos that are going to refuse treatment, I think is really unfounded. Largely because I think most consumers want to memorialize what's best for them, and probably the consumers who want to refuse all treatment aren't going to go to the trouble of writing an advanced directive. I think that would be very rare. So
I think if they're going to take the step to create the advanced directives, they've probably already bought in on some level.
Right.
To kind of looking at things that would help them. Mm-hmm.
So, as we said, when instructions are not followed, only that part is not to be followed. The rest is still followed. And the clinician needs to write in the record why the instructions are not being followed. Can they be changed? Well, absolutely. Generally, though, the way you change an advanced directive is that you have to do it during periods in which the person is capable or competent, so that the person, and I think Mary's going to give some advice about this, but the person can make instructions and update their instructions, but most states will stipulate that it's during periods of capacity when the person's well and not when they're acutely ill.
Mm-hmm. Yeah, the general idea is that you don't want to create your instruction when you're in crisis. Generally speaking, you want to really use a very deliberative process in making changes to your advanced directives, and you may, through your treatment planning process, want to build in automatic triggers for review, and I will talk about that in greater detail.
Great. So just to touch a little bit on the healthcare power of attorney, this is the document that allows a person to appoint someone as a proxy or a surrogate to make decisions during the periods of incapacity. And as we've said, it can be combined with the instructional directive, and in some cases it's two different forms. The instructional and the healthcare power of attorney are two different forms. In some states it will be one form. But it's easy to find that out in your particular state. And similarly to the instructional directive, any capable adult can execute one. Who can be a healthcare power of attorney? Well, any competent adult 18 or older, usually not a provider providing health care to the person. Again, you don't want to have a conflict of interest in the healthcare power of attorney. You really want someone who everyone will regard as as a clear agent of the consumer. So you want to avoid any concept of any conflict of interest. And we absolutely encourage consumers to have a list of healthcare power of attorneys in the document so they have a succession plan, because often you might appoint a healthcare power of attorney, but the crisis happens and that person's out of town. So most states will permit you to have a list of people who they will be approached serially during periods of crisis. So that's, I think, an important aspect is to anticipate that your healthcare power of attorney, which is actually usually called a healthcare agent, may be out of town. So to have a backup plan. Now, Mary's going to talk about some of the decision-making thought process that I think is very valuable.
Yeah, I mean, in my case, in the very early days, my trust level was very low for most people, and I didn't have a large circle of people in my support network, and it was certainly not going to be my family, as I said earlier. So there were a number of things that I wanted to consider. I wanted to consider who knows me, who do I think knows me, who do I trust, and who would respect me enough to try to put forward decisions that I would have made. So somebody who wouldn't substitute best interest thinking, especially where I had very clearly stated what I wanted to happen. And somebody, for me, it was very important to find somebody who believed in me, who didn't see me as an illness, but somebody who knew me in a different way and believed in me. And so through the process, I actually chose a peer, and it was a peer in a different state. She's somebody that I spent 4 years in a hospital with consecutively. She's somebody who was doing very well and had really come to understand her own health and had been really moving towards wellness. She was somebody that I trusted, who had seen me at the worst of times and had seen me doing better. She was somebody that I could trust, that I could say what I want to say, and I knew that she knew how to listen. She was somebody who took the time to learn about her role, what she was supposed to do, what the laws allowed it for. She was somebody who was willing to engage with the healthcare professionals. I mean, she was somebody who was a very good advocate and somebody who actually was able to communicate in a way that was not completely off-putting. So she was able to get people to buy in as she was advocating for my care. And as I said, she had an understanding of me beyond the illness, and so she was very much somebody who saw the possibility in me, and that was the underpinning of a lot of her work as my healthcare agent. That was really important. I will say that bigger impediment than finding witnesses for many consumers is finding a person who can serve as their healthcare agent. And if a person, and I believe very strongly that you should have a healthcare power of attorney as well as an instructional document. But for many consumers, the healthcare agent is going to be difficult to find. And so, people really want to work with the clients or the consumers that they see to really think through some of those critical elements. And then if you can find a substitute or a backup person, that's always a very good idea. In my particular healthcare directive, I now have my older sister as my primary healthcare agent. So the neat thing about the whole process for my psychiatric advanced directives is, as I've grown, the people that I'm bringing into my support network and using to help advocate for my healthcare decisions has also grown. And it's actually been a great process to build the relationship there with the family.
Okay. So what kind of powers does this person have? Generally, the healthcare power of attorney or the healthcare agent can make whatever treatment decisions the consumer would usually make, unless, and this is an important exception, unless the consumer stipulates that they don't want that person to have those powers. So, for example, they can strike out any powers that they wish the healthcare agent not to have. So, for example, we had one consumer who appointed healthcare power of attorney but didn't want that particular person to make hospitalization decisions. So they just stipulated that right in the document, and that's a way you can tailor the document so that you're most comfortable with it if you're a consumer. And then an important issue is how does the healthcare power of attorney make decisions? And the healthcare power of attorney is supposed to make decisions consistent with any statements that are in the instructional directive, and really make decisions that the consumer would want to be made. This is not a situation in which the healthcare power of attorney does what he or she thinks is best. The goal of the healthcare power of attorney relationship is for that person to speak for the consumer and to make decisions that are consistent with the consumer's expressed preferences. To do that, they can rely on the instructional directive if there is one. Excuse me. But they also can, review other materials that may be helpful, and they can discuss and review treatment information. Usually they can consent or refuse admission to the hospital, and consent or refuse medication, and just about any decision that a person can make for themselves, the healthcare power of attorney can do the same.
Mm-hmm. So as I had said earlier, in terms of the examples of these in my PAD, one of the coping strategies that I had that was particularly troublesome to my treatment providers was that I had some problems with self-injury, and quite frankly, the hospital was not helping me deal with that in any way. It was preventing it from happening, but it really wasn't facilitating my ability to adapt my coping strategies. So over a period of years, my PAD was revised to authorize the use of these crisis beds where I could actually learn and practice new coping strategies other than the self-injury. And so that was a real evolution, because initially when I did my first PAD, it was to kind of help me stay in the hospital a little bit longer so I could get a little more stable. And as I started to be able to be less volatile and in and out of the hospital, then the PAD also evolved to say, all right, now what do we do to keep you out of the hospital? What do you need? And so we were able to kind of revise the PAD. Now, of course, that required buy-in from the various treatment providers because, of course, with self-injury, people are very concerned about risk and whatnot. However, since we had been doing this collaborative project of creating and revising a PAD, we had already, in the process of those few years where people were seeing results, created that buy-in. And, of course, I had my great healthcare power of attorney as well as the psychiatrist. And by that point, my housing provider was on board. I was in programmed housing. And then I was able to look a little bit in greater depth about medications and really looking at trying some new and novel approaches to medication, as well as authorizing my healthcare power of attorney to make future decisions. Now, the interesting thing about that is that I talked with my healthcare agent very often, and there was no way that I could have codified everything in the instruction that she knew about me, and there's no way we could have possibly anticipated every future event that might need to be addressed. But just by having that close communication with that person and by actually bringing her in via phone to some of my treatment planning sessions, I was able to feel more and more comfortable that she was somebody who really knew in a more concrete way the kinds of things that were working and not working for me. So the PAD really can grow as the person's needs change, as they grow in their own recovery.
Great. So why don't consumers have more PADs? We've extolled the virtues of them, but why don't they have them? I think, one reason is that many consumers aren't aware of their right to create a PAD. Certainly, even in the 25 states that now have enacted them, the word just hasn't gotten out that these are legal documents that people have a right to complete, and frankly, in a lot of states, the clinics and hospitals have not stepped up to the plate to inform consumers about them, and they really need to do a better job in informing consumers about their rights to create them. In other states, I think, where there isn't a set-aside a specific psychiatric advance directive statute, and you can do it under the medical advance directive, there's also a lack of information about that many consumers aren't aware that they can put psychiatric information into the medical advance directive. They're also not always easy to do. I think Mary is a wonderfully articulate user, but for some folks, the concepts and the logistics may be difficult to complete for some folks. If consumers need help in completing them, the help isn't always readily available. One of the things we're trying to do is to train people so that they can provide help to consumers in completing PADs. And I think a final barrier, and I think Mary can comment on these a little bit more, is that, there's, for some folks, there just is a lack of trust, as Mary has suggested, and they may not feel that their wishes will be respected or that the healthcare agent will, uphold their wishes.
Yeah, and in some places, consumers learn about their right to create a PAD from their treatment providers, and so they don't quite get the difference between the treatment plan and the PAD, and therefore they see the PAD as just another vehicle for coercion. In the District of Columbia, what we really came across was that the healthcare providers were very ignorant about PADs, and although they were aware that their certification requirements required them to present PADs as an option, they were afraid to do anything with it. They were concerned about liability issues. And so one of the things is to really make sure that your healthcare providers understand what PADs are and how they're used.
Great. Now we're going to finish up in a few minutes, so we make sure we have time for question and answers. I think Mary's going to talk about a few lessons learned from her perspective in creating a PAD.
Yeah, I won't go into too much detail. We've touched on these things throughout this presentation. But really to think about the supports and the people that are helpful and are not helpful, to learn about the laws and regulations in your state, your jurisdiction, I think that's one very important thing that consumers should understand as well. Some of the laws, some of the terminology that's used, so that they can feel more trusting of the process. Also for consumers to really be talking to a variety of people that they know that they consider their supporters or that can become their supporters, so that people really understand what your goals are, what you hope to accomplish with your PAD, and so that everybody understands the treatment wishes. If people have, we'll go to the next slide. If people have a healthcare power of attorney, I mean, really, it's so important to choose your healthcare agent with care. And quite frankly, this is not a unique problem for people with mental illness. Quite frankly, there are a lot of people who write healthcare directives that don't really think through the process, so they want their godson or their goddaughter, but that person isn't really the person that is able to help you. You want to think about, is this person reliable? Will they honor my wishes, so that whenever my wishes are spelled out, they'll do what I ask them to do? Does the person know you well? Can the person be easily reached? Do you have a backup person just in case? And then we really want to think about accessibility. We'll go to the next slide. How do people know that you've got a PAD? Well, as Marvin has already said, you want to make sure that you, your healthcare power of attorney, and any of the people as substitute healthcare powers of attorneys, your treatment providers and your doctors have copies. You want to communicate to your support systems that you have a PAD, verbally or in writing. One thing that I have is a wallet card. The wallet card says I have an advanced directive for health care. I chose not to put mental health because I didn't want some people to freak out if they saw that. So I put health care in the event of any emergency, please contact, and then I put my my healthcare agent on there. And my healthcare agent, when she takes the call, will have a better idea when she hears what the emergency is as to whether the mental health part is relevant. And then just keep reminding people about your PAD and your treatment wishes. And then finally, it's very important to keep your PAD up to date. On the next slide, you really want to make sure that that your PAD is reflecting your situation as it changes. So you may want to think about automatic triggers or occasions to ensure that the review happens. So if there are people who are in treatment settings that mandated every 90-day treatment plan review, that's a great opportunity just to touch base on the PAD. Has anything changed? Do we need to look at this again? And then really folding in treatment planning, safety planning as part of your PAD activity and back and forth that way. And just really, whenever there's a medication change, automatically flag that to be reflected in the PAD. If it's germane to that. And so now I'll pass it back to Marvin so we can get to questions and answers.
Sure. So just finally, these are some resources people can go to learn more about it. We obviously want you to come to our resource, which is the National Resource Center on Psychiatric Advanced Directives, because we've compiled an awful lot of information that we'd like people to use. But we also recommend our partner in this endeavor. The Bazelon Center has terrific information and several other places. So let me open the lines. We can, if any folks have questions, we'll be happy to try to answer them.
Hello?
Mm-hmm.
I have a question. I'm from Maryland.
Sure.
One of the things we're looking at with the advanced directives is the question of how do you let people know if you get, how are hospitals going to know,
mm-hmm.
When you're really in urgent situation. And we've been looking at a lot of possible ways of doing it. One of them was flagging it on our the ASO here in Maryland. The other was perhaps doing it on the network of care. Mm-hmm. But I'm wondering how well it works with the wallet card, and do people really pick up that you've got the advance directive? That's a big question we're trying to deal with here.
Well, the funny thing is that since I created the wallet card, I haven't had to use my advance directive.
So it works.
But there were other things that I could build in. For instance, who to notify in the case of an emergency. So that was built in the early days of my advance directive experience, and that emergency contact was my power of attorney. Mm-hmm. So that was one way around that. And then I think, Marvin, aren't there some web-based resources that can be used?
Yeah, the U.S. Living Will Directory is a national organization that allows people to use electronic vaults to put their care documents in, and then certain states have electronic repositories, as I said, North Carolina does. The other thing we've done with, we've had consumers who want to have bracelets, so we use Medic Alert bracelets. We'll do whatever we can, but you're pointing out a huge issue, and that is getting it in front of people so people know that it's there.
Right.
In the case of our electronic directory, what happens is the person has a wallet card that says, here's my password, you can go to this directory.
Okay. Those are good ideas, and ones I hadn't thought of at all.
And then we also know some hospital systems are doing it. So the hospital system that I'm a part of, Duke Hospital, is setting up an electronic repository for all its advanced care planning documents so that the system has them. The VA has a tickler system that that in the VA it has a little screen that says if the person has one.
Do you know anything about public mental health systems, which I'm a part of in Maryland, any other states, and how they're handling it?
Obviously the easiest way is if you have an electronic health record.
Right.
And so places that have electronic health records like the VA are trying to do that. I don't know of any other mechanisms that are... Well,
in the District of Columbia, and it hasn't really been tried and true because it's still a work in process. But there are certain hospitals that people tend to go to, and so those hospitals may be alerted to the fact through the course of treatment planning or discharge planning, so that when the person comes back in, it's already a known fact. And then the community health providers are supposed to have a red flag on all folders that have advanced directives in them, so that when an emergency hits, the red flag is the alert to let the hospital or the urgent care facility know. And then I think they're also working on developing a system for we have a crisis program, CPAP, for them to actually interface, and that's one of the first things on the checklist when somebody is brought in under what we call an FD12, by the police to be screened for involuntary hospitalization. And so then on the checklist is to automatically ask about advanced directive.
Those are all good ideas. Thank you.
Any other questions or comments? Okay, then I guess...
I have one question.
Okay.
How do I get a copy of the PowerPoint?
Can you email me and I'll send it to you?
Sure, Julie.
Marvin.Swartz, S-W-A-R-T-Z. And this is true of anybody who's on the call. Marvin.Swartz, S-W-A-R-T-Z, at duke.edu.
Great, thank you.
I also have an additional question.
Sure.
And that is, in the world of drug and alcohol treatment, adolescents at age 14 can step forward and make decisions about treatment at that age. When it comes to advanced directives, are there any states that allow individuals under the age of 18 to sign off on an advanced directive?
In the District of Columbia, youth are allowed to have an advanced directive. I don't remember the cutoff age. They're allowed to create their own as long as their legal guardian
signs off on it, and I don't know what the cutoff age is when they can actually create their own valid healthcare directive, but I think it's 18, but I'm not for certain on that.
Right. No, North Carolina would be 18 too. So until you're 18 in North Carolina, your parents would make the decision. So it wouldn't. It's only when you attain the age of 18, and at that point you're considered an adult and you can execute them.
But the interesting thing is that in D.C., the model that we've tried to promote is one that encourages youth to work on creating them and to use it as an engagement tool with the family and the youth and the provider, so that it actually could be a youth-directed advanced directive that the parent is kind of sanctioning or signing off on.
That's interesting. That's interesting. Any other comments or questions? Well, you've all been a terrific audience, and we certainly thank you for your interest, and please, get the word out so we get more and more interest in this, because we think that this is a really exciting area for people to learn about and to use. And thank you, Mary and Neil, for inviting us to do this and participating.
And if people would like any follow-up, we're certainly open to that as well.
Yeah, Mary, you're close to me in Maryland, which is very. Is there a number I can contact you?
Yeah, 240-276-1747.
Great.
Who am I talking to?
My name is Susan Cadis. I'm in the Office of Consumer Affairs.
Oh, hi, Susan.
Hi.
Well, thanks for joining us, Susan.
Thank you.
Okay.
Okay.
Talk to you all later.
Bye-bye.
Thanks. Bye.
Bye.